Let's do some cases. So here's a case of an unruptured AVM. This is a 29-year-old gentleman who had presented with no significant past medical history, came in as a stroke alert to our system, NH stroke scale of 2, lower extremity numbness. MRI was done and demonstrated some flow voids. Here you can see a CTA that was done thereafter, and you can see, a bunch of squiggles, right? So this is going to be our straight sinus, vein of Galen, nidus. Here, this is a sagittal, so we're looking sort of at the top of the cerebellum, which is where this nidus is over the cerebellar vermis. Here's a coronal view, again looking at this kind of squiggle as the venous outflow is going up towards its eventual egress through the straight sinus. Catheter angiogram, this is a right vertebral artery injection. You can see the basilar coming up, and then you see the PCAs coming around. This is actually not directly attached to the basilar apex, as this picture may suggest. Look on the lateral here. It's actually coming off of the PCAs as they course around the ambient cistern into the quadrigeminal cistern, and that's where they give rise to these nidal feeders, okay? In this case, you can see that we have one of those nidal aneurysms. That's going to be our highest rupture risk feature, and that's what we want to target first. So in this case, a little coil in that aneurysm is going to immediately reduce that rupture risk dramatically. All right, now you've got options in terms of what you're going to do with the rest of it. In this case, we decided to go for a staged embolization approach. So stage 1, take out the nidal aneurysm. And then we start gluing off the various pedicles. In this case, going for a right SCA pedicle coming out and around the top. Glue that shut, get some reduction. This is what it looks like afterwards. Bring them back again, go for a left PICA pedicle. So this is coming from down low and coursing up around the back of the cerebellum. We're able to see that here coming out and around the lateral and over the top. That's another small feeder. Go small first and larger later. And we're able to take out some additional supply there. We do this multiple times, 4th, 5th embolization. All right, so this is the result of our 5th embolization. There's still substantial nidus. We've sort of taken all these small feeders that we can. We don't have a good arterial pedicle. These are all off sort of thalamoperforators, so high-priced real estate. What are you going to do? Options, surgery, absolutely. That's definitely an option. This is in, this is in a pretty good location for surgery. The cerebellum is very tolerant to transgression, so it shouldn't be a problem. But in this case, we wanted to try something a little bit different, so a transvenous embolization. We haven't talked about this very much in our short time together here, but this is the idea that you're, instead of going and pushing glue from artery to capillary to vein, you're pushing it retrograde, so from vein to nidus to artery, okay? So in this case, what we're doing is we're going and actually putting a very large catheter up and around, so up the straight sinus, down Galen, and all the way into those little, like we talked about, the alveoli type structure of the vein. And then what we do is we put a wire. We work with the cardiologists who put a pacer wire in the heart, transvenous pacing. What that allows us to do is to essentially drop the blood pressure to nothing. So if we're not stopping the heart, this isn't the adenosine trick. We're actually boosting it up. So we have a blood pressure of, a map of 30, because we're now pacing at 200, right? And that's really nice because you can turn it on and off. There's complete predictability. You say, okay, cardiologist, hit the button. You now have 30 seconds to do what you want to do, or a minute and a half, whatever it might be, during which time they're controlling the heart and you're taking care of business on the embolization side of things. And that allows you to be able to push sort of retrograde upstream and get very good penetration of the nidus. You can see here glue everywhere. That nidus is completely obliterated. Patient did very well. Okay.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.